Stay out there, not in here.
Officer down, you know the drill.
16 gauge in the right AC.
Definitely needs an airway.
Yeah, keep it up. You know, Ricky, you're in good hands.
So, like, already there's so much jargon here. So, First of all, we should establish that we're continuing this story of this active shooter at Pitt Fest. We're picking up where we left off with episode 12. We're now on episode 13. And right away, they get into this resuscitation. This person has been shot. They say, we need an airway because he's got blood on his face. Part of his face has been injured. And so they need to intubate him to protect his airway. They say they have a 16 in the right AC, which means a 16 gauge IV, which is a big IV in his right antecubital fossa. AC is this part of your arm here where we typically put IVs, and they're calling for 100 of ketamine, which is a sedative, a dissociative agent that we use to intubate people.
Yeah, it might be helpful to give some perspective on a 16 gauge. If I'm a patient in the hospital and I'm not super dehydrated or I'm not bleeding, right? So someone needs to get IV access in my arm, what gauge it would be kind of a typical go-to for me?
Yeah, so we usually will do a 20 gauge IV, and there's a color code for the IV colors. So if you get an IV in the hospital, you can actually see which size your IV is.
Sorry, I'm used to the glide scope.
Spoiled by technology. Dana, you got a bougie back there?
Completely out. Used them all out. All of you. Into PH2 now. You can watch from the window.
So she says that she can't intubate the patient. She's used to the glide scope. So in the emergency department, when we intubate somebody, we can use what's called direct laryngoscopy, which is what Dr. Robby's doing here. He's looking with what's basically like a metal stick with a light at the end of it that you put in the patient's mouth to visualize their vocal cords. And you visualize their vocal cords by looking with your eyes into their mouth. There's what's called video laryngoscopy, where that thing that he has in his hand is replaced with a video camera at the end. And so the device that goes in the patient's mouth is actually a video camera. And then you look on a screen next to you to see the vocal cords. And the most popular brand of video laryngoscopy is a glide scope. So we kind of refer to it as the glide scope. And what she mentions is that she's used to the glide scope. She's not used to doing it this old school way that Dr. Robby does. And it's actually a problem in emergency department resident training now that everybody has become so familiar and comfortable with the glide scope, with doing it with this new technology, that people are less familiar with this direct laryngoscopy, this old school way of just kind of sticking the light in and looking.
Better?
Not really. Radial pulse?
Still has it, maybe a little weaker. I can try and give you a bubble.
Yeah, go for it. No, nothing. I'm not seeing anything. Okay.
He can't pass the endotracheal tube. He can't see the vocal cords. She pushes on his chest, which is one technique that can be used because when you push on somebody's chest, it might create a little bubble of air where the vocal cords are. That's sort of what they're giving a shot with.
It's a control crite kit.
Oh, this per
Behind, so you can't miss. Good. Slide in the introducer.
Cool. So he's not able to intubate this guy through the mouth, right? He's looking with that direct laryngoscopy that we spoke about, that light in the mouth with the laryngoscope. He doesn't see it, can't intubate the patient, and he can't breathe. So they're going to do what's called a surgical airway. So instead of trying to put a tube through the patient's mouth, they actually cut into the patient's trachea through their neck. And we touched on that last time. That's called a cricothyrotomy. So in this case, so typically in a regular emergency department, there are techniques that we use to make that hole, and they usually use this long piece of plastic called a bougie. Cut the hole in the neck, they put the bougie through, and then they put the breathing tube, the endotracheal tube, over the bougie and secure it. Here they're using this separate tool that's used in military settings where it's kind of all in one. They have, this maneuver, and it cuts the neck, and it puts the introducer in, and they put the tube, and bing, bam, boom, and it's done.
So you might wonder, why can't he just give it a shot and try, right? Like, what's the worst that could happen if he can't see exactly where it's going to go? And the problem is obviously that not only do we have the trachea in our neck, but also the esophagus.
Exactly. Yeah.
Right. And if you're going to be pumping air into what you hope is the lungs, if you intubate the esophagus, then you're pumping air into your GI tract, right? Which goes down into your stomach and can cause all sorts of problems.
That's exactly right. Yeah. The whole trick, the whole task of intubation is to put a tube in somebody's throat and have it go into the trachea and not the esophagus. That's basically all that we're trying to do. And so all of this looking and feeling and all of the discussion that they're having really just comes down to, is the tube in the trachea or is it in the esophagus?
Keep clean.
Again, that lousy CPR. Don't do CPR that way. This is for TV.
He needs a big central line for a fast transfusion.
You can't do an IJ without an ultrasound, especially on a guy this big.
You'll kill him if you collapse so long or hit the carotid.
I'm not doing an IJ. I'll hook that bloodline, bring it up here.
Okay. So in a typical patient and a typical day at the hospital, we're putting IVs in the arm to give somebody medication or even blood or IV fluid. But if somebody's very sick, the size of the vein in the arm is not enough to give them the amount of fluid or blood that they might need. And so we place what's called a central line, which is essentially an IV in a larger central vein of the body. The most common site to place a central line is in the internal jugular vein in the neck. So you've probably heard of the jugular vein. We have an external jugular vein, which you can see if you bulge out the veins of your neck. The internal jugular vein sits deeper inside the neck, close to the carotid artery. And we basically place a large IV in the internal jugular vein to be able to deliver that medication or that blood.
You have to go in blind. This is the only safe way. A centimeter from the lateral head of the sternocleidomastoid, a centimeter clavicle, aiming at the contralateral nipple.
So that's usually done in this day and age under ultrasound guidance. So we put on a sterile gown, done as a sterile procedure. We go to the bedside with the ultrasound machine. We look, we take a big needle just like he was holding. We place it under ultrasound. We pull back on the plunger and we see that flash of blood fill up the needle. We know that we're in. Then we take a wire, we feed it through the needle, and then we take that big IV catheter, place it over the wire, take the wire out, and then we have that big IV, that central line in the internal jugular vein. And in this case, he's using this kind of lesser used technique. And so he calls out the landmarks that he's using to place it. So he's saying, I'm going this far away from this structure, this far away from this structure. When I put my needle there, I know that I'm going to hit the vein right where I need to go.
Yeah, and there might be another case of central lines that folks are familiar with. One of them that you gave the example in resuscitation, and we want to give large volumes of blood. But sometimes you may have seen a central line in folks who are receiving chemotherapy in the outpatient setting. And it's a specific type of central line that stays in long term, which is one of the kind of unique things about getting central access through this way. You might have seen, or some of you might have had, a chest port on, which is one of the ways to get central access, or what's called a PICC line, which is a peripherally inserted. So it's inserted through the arm, but instead of ending here in the arm, it actually goes all the way into the big vein here in your chest. And there are certain medications that are safer to be administered that way, like weekly chemotherapy and having to go back in, and then they need repeat access. We can leave those in safely for longer periods of time.
Inguinal GSW with active bleeding.
Try an Israeli bandage.
It's at the top of the leg. There's no room for tourniquet above the wound.
Well, let's just hope the hemostatic bandage works.
They're right that this type of bleeding is more difficult to manage, or can be more difficult to manage, because you can't put a tourniquet proximal to the wound. There's nowhere higher up, so to speak, to put the tourniquet because you're already as high as you can go. And so those can be more difficult to control.
Right. I think they use this acronym that we use quite often, GSW, which is gunshot wound. There's a lot of acronyms out there in the medical world, but this is one, a pretty common one in the world of trauma. But yeah, difficult scenario.
Can you tell us if this is Vincent?
Yes, that's Vincent. Can I see him?
Vincent had a gunshot to the head. When he arrived here, there was no pulse or breathing.
This particular environment it's just a kind of a impossible place to be able to do this well, and breaking bad news is never something that's done easily. When I break bad news to patients, I try to set up the situation as best as I can. Actually, a lot of preparation beforehand can help make these moments go more smoothly. So making sure folks have, the relevant family there, having a private space, having some Kleenex nearby if necessary, and, kind of gauging what they know about the situation gently, but also directly kind of giving the negative news here. This particular dynamic doesn't leave room for a lot of those aspects that we aspire to when we're breaking bad news, but all things considered, I felt like they did a good job.
In my experience, it's very common that what this woman said of can I go see this person? That even in patients who collapses at home, even a very old person who's chronically ill and they're not breathing and their heart has stopped and CPR CPR is performed in the field and they're transported to the hospital, most emergency providers who hear that story have a good sense that this person does not have a high probability of survival. And yet, in my experience, often by the time the family gets to the hospital and we have a chance to break the news to the family, if this person has died, they're not coming at it from that perspective. They kind of assume that we've saved their life and they want to know when they can come see them.
The second unit fast, and then we'll do another pulse check.
You need the second line?
For FFP and platelets.
You sure, Robby?
So if we get the plasma, I'm going to take over compressions. Swap.
He says she needs a second line, and the nurse says, "You sure?" I think it speaks to taking care of somebody that you know. I think you start to I don't know, at least in my experience, it's very different taking care of somebody that you know, because you start to add on other things that you might do or think, well, maybe let's do something extra for this person. And you start to, I think, stray from the algorithm. And I think it often results in worse care.
Yeah, I think it's one of those, there's this kind of classic thought that it's sometimes quite difficult for doctors to treat people that they know. And I would say the more acute and sick that patient is, the more opportunity there is for that care to be kind of warped or distorted in a way because of the experience we're having as the doctor, right? Which is the amount of anxiety and discomfort around being in the position that Dr. Robby's in here.
You're in the ER PTMC. What's your name?
Martin?
What'd you take, Martin? You overdosed at Pitt Fest.
Took one Percocet so I could dance. I've got a bad knee.
So this guy came in with a suspected opioid overdose, and one of the reasons that they suspected it is that his pupils were pinpoint, meaning they're very small. So if somebody overdoses on an opioid like fentanyl or morphine or heroin, when you look at their pupils, they're very, very tiny. They don't respond to light. And so they gave him Narcan or naloxone, which reverses the effects of opioid overdose. He woke right up.
Yeah, there's two things I look for in this case. One is definitely pinpoint pupils, but also number two is how many times a minute somebody is breathing.
That's right. Yeah.
Right? So if somebody has an opiate overdose, they are breathing very slowly. I mean, they might be breathing 7-8 times a minute,
or potentially slower if they've stopped or nearly stopped.
Right. And you can just watch their chest rise. And, it's actually one of the things you can even see from afar because it's so visible. This is probably the one patient we've seen so far that still would have ended up in the emergency department, no matter what, because this is the type of thing. As if somebody, maybe at the festival, somebody has Narcan, which often at music festivals these days, they will have it on staff and they'll be able to give it to him, but still needs acute care in this way.
Yeah. And Narcan is available for free at many locations. And Narcan is also included in Duration Health medical kits. So this video is sponsored by Duration Health. I'm the founder and CEO of Duration Health, and we provide off-grid medical kits for living and travel in areas where there might not be access to a physician. And our kits include prescription medications like emergency antibiotics, anti-nausea medicine, EpiPen. And the way that it works is before you go off-grid, before you travel or in a remote location, you talk to our doctors. We prescribe medication that you might need if you get sick. We package it all up into an orange bag. We ship it directly to you. You bring it with you. That way, if you do get sick, you already have everything you need to feel better. We are the expedition doctors for the North Face Global Athlete Team. So North Face athletes who are going out to remote areas where obviously there's no doctor or pharmacy, they bring our kits. We provide the ongoing support should they run into trouble. And you can have that same level of protection and support through Duration Health. So check out our 20 kits built from over 70 different medications, durationhealth.com. And yeah, thank you, Duration Health, for supporting this content.
Okay, we're done.
Stuff from 1947.
It's sort of unfair and it's difficult for somebody to take care of somebody that they know in a situation like that. You feel responsible for not being able to resuscitate them, be the one who has to break the news. That's what the rest of the team is there for. Would have made more sense for him not to be the lead physician taking care of that patient.
I agree with you. I think it's an impossible dynamic.
Prepping for Roboa?
Are you crazy? Did Abbott approve this?
He said, do what you have to do. Pendings are all tied up. If I can blow up a balloon in the aorta, it'll stop the bleeding.
So she's doing what's called REBOA, resuscitative endovascular balloon occlusion of the aorta. And this is a real procedure. They kind of amp up the drama. They're like, no, we can't do it. It's actually a pretty well established procedure, and something that could be done in this situation.
I'll cut off the blood supply to half her body.
I'll only go in a few inches. Zone 3 below the kidneys.
They thread the balloon, the catheter up through the femoral artery, get to the bottom of the aorta, blow up the balloon, occlude blood flow to the lower half of the body. And one of the other docs says, you're going to cut off the blood supply to half of her body. That's kind of the point, is that you cut off the blood supply to the lower part of the body so that that bleeding stops and you buy yourself time to get to the operating room. It's sort of like an internal tourniquet that you're occluding that blood flow deliberately to stop the bleeding, knowing it can't stay like that, but that you buy yourself time to get to the operating room to fix it.
Yeah, exactly. And I think the big turning point was when they realized that she had, I think they mentioned a few minutes ago that she has an internal bleed in addition to the one that they're able to see. So then no external tourniquet's going to help you in that situation. You've got to do something to cut off blood flow internally in the body, like they show here.
Yeah. What number do you have on your wrist? Anyone?
So in addition to that just being so awful that he's like, what number do you have? The number of patients who have died and what number do you have? And like, that's how he's going to figure out which of all of these bodies is the one that they're looking for. It's just terrible. But when they pull back the sheet, she still has the endotracheal tube in her mouth. It's not connected to anything. And she still has the endotracheal tube holder, that blue piece of plastic around her face that's holding on to the tube. And that's real. If somebody is intubated in the emergency department, especially if it's a patient that might go to the medical examiner, that's part of a crime or suspicious situation where there's going to be an autopsy done of the body, everything has to stay in place that was put in by the emergency department team. But after somebody dies, we don't then start disconnecting the endotracheal tube and the chest tube. We don't like pull everything out. We just leave everything exactly as is, and the patient goes to the morgue that way. So it is realistic that if somebody had died in the situation, when the family member comes to see the body, that they would have those lines and tubes still in place.
Why couldn't you save her? I mean, this is what you do. Yes, no, I don't know. And I don't know how many people I've helped today, but I can tell you every other person who has died.
First of all, I think that in my experience, having taken care of people who later died, it's certainly the exception that family members come back and say, why haven't you saved her? I think that most people are very appreciative of the work that we do and understand that like there are limits to modern medicine and limits to what we can do. In a situation where somebody places the blame on the healthcare worker, and I've been in that situation, and that's a difficult situation to be in, it's, I think, part of the reason why we don't take care of people that we know, just because it makes it so much more difficult to bear when that kind of criticism is directed toward you and it's somebody, you know, that you love.
Yeah, I think that's completely right. And he made this comment. I'm out of a lot of emotions there, but I'm going to remember her long after you do. And there's just this way that I think these moments really live on with people. And especially, you can imagine him thinking back to all of the decisions he made in a split second to try to save her. And it's just, these situations are set up to feel really bad. Even if in some part of his mind, he knows he did everything he could and really the best of what he could do. And yeah. You just see the toll it takes on all of these people, but for him at the end of this specific shift, right? Obviously he's wrecked. This is a horrible, horrible situation overall, but so much added complexity when it gets personal like this.
I think it also kind of raises the question of like, how personal should we take these things as doctors? Do you get to, on one hand, setting this patient that he knew personally aside, you could say, it's not your fault, Dr. Robby, like you did everything you could. Don't worry about it. Put it out of your mind. Like this isn't about you. But I also think that taking that personal responsibility also helps us do the job.
Right.
And so there's kind of this balance that has to be struck between like taking it as personally as we can and then also leaving it behind in a sense. And I think that that's something that, every medical professional watching this can relate.
Yeah, I think it's one of the hardest aspects of the job. But I think you are right that there is a personal responsibility that we all do take, and it drives us to do great work for our patients. It's driven Dr. Robby to do what we've pretty much seen as miracle work throughout this entire episode so far, right? The amount in which he is supporting his whole team and the number of patients that he saved, like it's part of that personal responsibility that gives him and lights that fire. But we're also seeing the other side of that weight here, I think, at the end of the episode.
Well, what an episode, and what a note to end on. Thanks for watching. If you enjoyed the content, please like and subscribe. Leave your comments below. We'd love to hear from you. We read every comment. And yeah, thanks for watching.